So this is less about resuscitation and the medicine and more about communication with the family. So it's going to be kind of a hard topic to talk about because it talks a little bit or a lot about death. So we're going to talk about the family participation during resuscitation, termination of resuscitation, how to deliver bad news, and just talking about death generally. Not in any specific order, but almost that kind of order. So the population under 18 is about 22%, and we actually see about 20% of patients in the emergency department that are under 18. I know we see older than that in the emergency department, but in the pediatric emergency department. It's about 1 in 15,000 pediatric deaths. And about a century ago, there was more than 30% that were less than 5 that died. So we're doing something right. And what's causing the death, right? It's firearms, trauma, MVAs, and now drug overdoses or poisonings. And that's the main thing that's causing the deaths now. The problem with deaths of a pediatric patient in the emergency department is that it's so infrequent, even though it feels like it's happening a lot. And the magnitude of the tragedy, it's a lot more than we can handle. And that's a challenge for us in the emergency department because we have to face this. The AAP, along with ACEP in 2014, put out a technical report talking about just a child dying in the emergency department and how it was so uncommon for professional clinicians to face this and as a singular tragedy. So what is the challenge for us, right? We don't see that many patients that are going to die overall. If you're a pediatric resident, you may go through your entire residency without seeing one unless you're in the emergency department, sometimes in the ICU, but those are more chronically ill kids. In the emergency department, you have to carry out complex tasks fast, and you have to work together. There is a limitation as to what we can do, and we have to, at the same time, develop a relationship with the family that we've never met before. And that all has to be done within minutes. So there's a Children's Die Improving Palliative Care and End of Life article that came out. And one of the quotes in there was a mom talking about when her child died, how she didn't have any idea of what was going on because nobody was talking to her. So should the family be allowed to witness the resuscitation in progress? Raise your hand. Yes? No. Okay. It's a difficult decision. So family presence during pediatric trauma, there was a prospective study done that was trying to figure out if there was negative outcomes to having the family in there when you were trying to resuscitate a child. The main thing is the stress on the team, right? Everybody worries about this. The trauma team worries about it. It's the only thing we all agree on. EM and trauma is literally the only thing we agree on is it going to do anything? So for the family that's watching, are we psychologically damaging them by having them in the room? Are they going to get in the way when we're trying to take care of their child? And then what about like the potential like adverse effects on the family? And is it going to decrease your performance when you're trying to take care of this child? Trauma evaluations and milestones showed that they were not affected by family presence, and the family did not interfere with patient care. There was an 18-month study where a few families were taken out because they couldn't take the intubation. They couldn't take there was apprehension when the resuscitation was going on. And then 1 or 2 families were asked to leave, with one of them being in that study that they thought that person actually, instigated the trauma on the child. So a family presence in your resuscitation actually decreases litigation. It does not impact the discussion that we have on injuries, going through the trauma. We see this, we see that. It does not impact on educational teaching. And from the family's perspective, they actually witness you trying as hard as you can to save that child's life. And that compassion and concern that you show during the resuscitation is actually something that they carry with them. but there has to be a structured program in place. I don't know if we have a true structured program, but I know that I call on everybody that I can to help me. I call the social work early. I call other residents and faculty early. And then I try and set up a team with me so that not only do we have the medical resuscitation going, but we have somebody taking care of the family. And that dedicated person is going to be, can be a medical person, so a resident, or somebody who's able to tell the medical part of it, and somebody who can actually just hold their hand and kind of help them through the whole process of watching the chaos as it's falling into place. So there's two groups of people. There's going to be the for and the against. And the against say no families. They're disruptive. It's emotional strain on us. There's lack of understanding. And then the legal issues. What if they see this and it wasn't supposed to do that? And then the increased stress on you again. And then does it prolong resuscitation? So it might, but keeping the family in the resuscitation, you have to, you support the patient. There's a perception of participation and there's reassurance. And we actually probably treat the resuscitation with a little bit in a different kind of mindset, in that we're more respective of the privacy, pain, and dignity of the patient. One of the cases that I had where I actually couldn't get the mom to leave was a 3-year-old came in and the mom actually was holding his feet and they moved him from the gurney onto the bed. He was awake, he was alive. We did a whole trauma resuscitation, but she wouldn't let go. I helped, he had a head trauma, so I helped actually take him to CCT. The mom barely would get out of the CAT scanner. So I brought her out and I sat down with her. And I just started talking to her. And the first thing she said to me was, they didn't bring the other one. They didn't bring the other one. And then I understood the enormity of what she was talking about, because the 9-year-old had died on scene and they did not bring him. They only brought the 3-year-old. But it took me a minute to understand what she was talking about. As circumstances would kind of reveal themselves, he was up in the Catskills hiking. And we go to the Catskills a lot. So I actually called my husband and asked him the name of the park ranger of the place we go to, called that park ranger who found the family, who found the father and his team, and then had them come down and just told the friends that they have to drive and not the father. So they knew about the accident, but they didn't know about the enormity of the accident until they crossed GW Bridge and they had 10-10 winds on, and the father heard on the news that his son had died. So it's really a terrible thing to be let in on. One of my residents here was part of a resuscitation that I did, where I let the father in. After we did the initial resuscitation, I went out and got the dad so he could come in. And I could tell by the look on the resident's face that they were not expecting me to bring the family in. It's important to do. I apologize now that I didn't say anything before, but it is something that I actually do pretty regularly. So termination of resuscitation. This is a hard one. When you are a new attending, I promise you, it's very difficult. When you stop a resuscitation, I know as a person, I have actually gone back about 10-20 minutes later, just to make sure. It's really the weirdest thing, because you have all this power, but the humility and and how humbled you are at that moment to say, okay, I've stopped doing this. It's pretty big. So when do you stop it? PEM physicians are likely to stop a resuscitation about 25 minutes after not getting ROSC. That is the shortest time period of EM and anybody else. Why does EMS bring in a patient that they know is not alive? Why do they bring a patient in doing CPR in progress? And it's for 2 reasons. One, the setting that they are in when they scoop and run with that baby, it's pretty chaotic and they're so uncomfortable. And there's no guidelines to say, don't resuscitate the baby. If they call Medical Central or whatever it is that they have to call, they'll find out, they'll be like, no, just start CPR, get to the hospital. Because that is not a place, aunts, uncles, moms, dads, grandmothers, neighbors, everybody's at you. That is not a place for them to be like, baby's gone. No, they come. Termination can be done in a more controlled setting with us, because we have more people to help us, even though our ED seems chaotic, out there is even more chaotic. So do you start resuscitation on babies? I think at county, we had one mom code 52 come in. It was an outside delivery, but it was actually a non-viable fetus, and the baby came in, but they logged the baby in instead of just keeping the baby as a specimen, which is cold-hearted to say, but if they're under 22 weeks, they're not, the viability in New York State is under 22 weeks, under 400 grams. So you do not need to start CPR on those babies. And if there's CPR in progress because they have brought that baby in, if you are sure that the baby is less than 22 weeks, then you can actually stop it after 10 minutes of not getting a heartbeat back. What if you're not sure? Do what you need to do, start the CPR, but call NICU because they're supposed to come down anyways, and they can help you stop the termination by talking to the family and helping you kind of put the team together that's going to do it. And these things are supposed to be done not by us in the ED. They're already supposed to be put in place, whether there's a DNR, whether there's a MOLST. And I can tell you, in February of 2019, a mom brought in, well, EMS brought in a baby, a prosencephaly. He had like one kind of airway. There was no nose, there was really no mouth. There was just one thing. And she was just grunting. She was gray. Her heart rate was 80. Her respiratory rate was 80. Her SATs were 80. Everything was just bad. But there was nothing that I could do when I was trying to resuscitate her, putting oxygen on. I gave her racemic. The mom's whispering in my ear, she's DNR. So I kind of turned to her and I said, does that mean you don't want me to do anything? And she goes, no, I don't want her dying today. All right, got it. Like, you keep going. So I did not put a line in the baby. One leg got epi, one leg got ceftriaxone. She got racemic. And actually, by the time I called the floor on the PICU, she was pink, breathing well, looking well. So I called the floor and they were like, well, we don't want her because she's came in such extremis. She's got to go to the ICU. ICU call, I talked to them and they were like, we don't want her. She's DNR. We just looked in her records. So the ICU attending actually came down because I said, what do you want me to do with this baby? I'm not sending her home. Mom doesn't want to go home like that. So then they put together a MOLST form and several weeks later she died, but that is not the place for us to figure that out. Somebody has to help us. That's not our job. So does death mean failure? How many of you think it means failure? Good. So modern medicine has cultivated an unspoken belief that death is a failure on part of the medical system. And the culture that the ED is perhaps the most particularly vulnerable to this belief. It is not, okay? What I think out of doing all the reading is that we have an obligation to save a life, but sometimes we can't. And other times we shouldn't. And kids die. So we have to accept that. And that's the hardest thing to accept. So when a child dies without forewarning, a family's encounter with the medical personnel may be brief, but it is a profound, enduring impact. I have only had one deposition in my entire career. And that mom, the only thing she really remembered was my hair was kind of like this. She goes, I don't know, her ponytail was floppy, so maybe she really did a good resuscitation. That's all she could remember about me as a person, as a character. So they do recognize things on us that are important. So like when you guys come, well, not you guys, but especially our pediatric team comes all dressed up for Halloween. I said, you're allowed to be here during your rotation, but you got to take all this stuff off. If there's a resuscitation, you got to be able to get back into normal mode. So you can't have your face painted. You can have a costume on as long as you throw something on it. You can take off your ears or your antennas or whatever the hell else you got on, but you can't go into a resuscitation looking like a cartoon character. So the two things we need to do is deal with the families in a caring and compassionate way, nothing else. They're going to need time to understand the process, and they're going to have to learn to say goodbye. So if there are suspicious circumstances, one of my moments that I take away from me as a faculty member is a time when I did not let the mom see a dying or dead child, actually, because PD said no, and I let them kind of change my mind. It was a winter day. There had been a lot of snow. The building that she was in, she had just moved into that afternoon. The child, a 4-year-old, had found her way out of the apartment. The door self-locks behind it. She found one door that opened. That was the rooftop. She went on the rooftop. She pattered around. They saw footprints from the door to the edge, and she walked until she fell. They had just cleared the sidewalk, and she had landed on the ground, and she died. EMS brought her in. PD brought the mother in because they went from door to door trying to figure out which child this was. So by the time PD figured out which mother it was that this child belonged to, they brought her in. But they did not allow me to let her in the resuscitation. And it is the one parent that I did not allow to see the child after death. And that moment stays with me as a very heavy moment because I let them do it and I will never let them do it again. She doesn't have to touch the baby. They can be in there with her, but she has every right to see that child dead in the first moments. So don't let EMS tell you, PD tell you that no, they can't do it. It is your house. Find somebody that's going to help you do it. Call the ADN, call your supervisor, call somebody. So how do we prepare as doctors to do this? So we have to be trained in delivering bad news. We have to understand the emotional burden of the family. And we have to debrief as a team because what we have found is debriefing really helps. I have had more than one resident who has left a shift, come back the next day and not be able to function because of the sounds, the smells. You would think an emergency medicine resident can handle the sounds and the smells of an emergency department. A senior emergency medicine resident had to leave at rounds the next day after we had resuscitated somebody and lost a child the day before. You are not exempt from this. You are not immune to this. We need to help you process what has happened. I have had pediatric residents who went home and thought we had killed a child. No, we didn't used to do debriefing. They didn't get to process it. I have had medical students who were part of resuscitations who I actually spoke to the next day in a kind of a facilitated setting. And I said, you were with us yesterday. Can you tell me what you thought? And his first words were, we killed a kid in that ED. And I was like, wow, he carried these words around with him all bloody night. Nobody bothered to talk to him about it. So it is our job to take care of each other. So acknowledgement that death is not avoidable. Remembering that we did the best thing that we could for the patient. We applied all the interventions that we knew how, and we withheld care when we thought it wasn't going to help. And the other question is, are we cold-hearted? We keep moving. We have other patients to see. We're laughing in the corner. We're drinking coffee. The parents are still with the family, is still with the patient. So we have to remember that what we do and how we carry ourselves, it's a vision that a family has of us. So I'm not saying don't function, don't carry on, but that's how we have to kind of function and carry on. It's a kind of routinization of disaster that happens to us. We know that we have to carry on. We know we have to take care of the next patient. And some people are mean that have been waiting. You know, I literally have had another parent say to me, oh, so it took all of you to kill the kid? I was like, no, ma'am, we will get to you next. So you have to kind of not displace your frustration and anger on the next parent who does not have any understanding of what you have gone through. Having said that, a 16-year-old father who witnessed his son's resuscitation and then waited outside, and I went outside to talk to him. The kindest words that have ever been said to me in my practice were by that man when he said, I have never seen anybody work so hard for another person's child. Those words mean more to me than almost anything else that has ever happened to me. So just remember that people kind of can say nice things and very mean things. Skill and compassion is conveying bad news in the most appropriate and powerful way that you can to the affected family. So delivering bad news is hard. There's a lack of training, even now, even with our kind of trying to bring it to the forefront of what we're supposed to do. But it really is something that you need to practice because you're going to have to do this one day. And it's not fun to do it, but you do have to try to kind of become comfortable with it. So when a child has died and they put the family in the family room, and I'm trying not to call it the grieving room, because if you call grieving room or bereavement room before you've told them what's happening, they know that they're coming into bad news. So call it the family room. Like, let's just call it the family room. Take a moment to acknowledge your own feelings, whether it means to go throwing up for a minute, means washing your face, means taking a moment to just sit there, talk to a colleague, whatever you have to do. And then it's a silo moment, so put it aside. Self-reflection is important, but not in the moment you're going to take care of the family. Because you have to be the kind of the anchor at that moment and to help the family. Know the child's name. I don't care if they came in DOA. I don't care if they came in as an unknown, figure it out. Figure out the child's name because that is really, really important. An attending should be present in a pediatric death notification. One of the papers talked about how a family member felt that if an attending wasn't present, that we weren't giving them the utmost respect that was due to the family. So take somebody with you, that's faculty. Take the social worker with you. I don't let them off the hook. I call them the first minute that the patient comes in. They know it. Some of them are like, what am I gonna do? You're gonna come stand there, that's what you're gonna do. And then you're gonna figure out the next steps. Find a quiet place for them to sit. Hopefully there's water, there's tissue, check your appearance. Introduce yourself. You can shake their hands if you want to, sit at eye level if you can, but make sure that you're near the door because sometimes it can get really rowdy in that little room. I am so sorry that I have bad news to give. You have to say something to start. Give them a moment to process your words. Some of them will start wailing at that moment. Look at them in the eye. Be articulate, speak slowly. We did everything we could for the child's name. And then be quiet for a second. But you have to use the words, your child has died. Don't say they've passed on. Don't say they've passed away. Don't say they're gone. They have died. It's a very interesting word. My dad died 2 years ago, and whenever I speak about him as death, my husband will say, can you not say dead? Can you say passed on or passed away? And I said, I am so used to saying dead and death that I can't just say passed away for you. But now I've tried to incorporate that in my speech when I speak about him because he can't handle it. Okay. Sit quietly after telling them that their child has died. When we are nervous, we want to keep speaking. Don't. It's going to feel like a really long minute, and it is a really long minute. Just sit there. Let them speak first. If it takes too long for them to say something, you can say something again. Like, I am so sorry for your loss. Please don't say I know how you feel unless you know how they feel. And hopefully most of us don't know how they feel. So say, I am so sorry for your loss. You can just say it over and over again until somebody finally says something else. You can say, I cannot imagine how difficult this must be for you to hear. So if they're alone, ask if there's somebody else that you can call for them. You can give out your phone number and the ED's number so that they have somebody to call us. It's actually been written that you're allowed to do that. Don't give them your cell phone, but give the hospital number so that people can contact us. So once the news has settled in, give them a few minutes and then try and get a little bit of a medical history or what happened that day or what they remember of that day. And then once you've done all that, then you can try and giving them the next steps, which is I'm going to be doing this, this, and this. The ME is going to be coming. The police may have some questions, but all this takes a good 10, 15 minutes sometimes. Today is the day the family needs to understand that their world has changed. Today is the day that they need to understand that their life is no longer normal to them. And they have to learn to say goodbye in a meaningful way. So we have to be respectful of that moment. Use a social worker to help bridge the gap. Use another resident to help bridge the gap. If you're the resident who's actually taking care, find somebody else. Sometimes a medical student can handle the burden, but you have to make sure that they can handle the burden. They do attach themselves to one or two people. So they're not trying to be annoying. They just don't know what else to do. So they just hold on to you really tight. So try not to be too affected by that. But you got to finish your work. So you may have to trade off. Somebody has to do the documentation, make phone calls, have the nurses finishing putting their charting. They're going to ask you how many epi you gave, what you did, what you didn't do. Don't be annoyed with them. They got to get their stuff done. Have someone stay with the family. And I usually have now tagged the social worker to do that. And then you're probably going to be repeating this "I am sorry" speech again and again as the father shows up, the mother shows up, somebody else shows up. Try and have an accurate demographics of the patient. Call the pediatrician. I will tell you why. Because the pediatrician's office will call the next day and say, they have an appointment on Friday. We just wanted to confirm with you. Don't do that to the pediatrician, please. Okay. Make sure that we call organ donor. ACS will be called by the social worker for any pediatric death that the police have not called in. It is just kind of part of protocol. There's no really discharge papers that print out, but they do need the medical record number, the ME number, so that when they call the family care center for the ME's office, they know like what patient they're talking about. There's evidence preservation. You're going to put the shoes and the clothing all in a bag. You try not to clean the body too much because that's what the ME wants, is you not to disturb the body per se too much. It's professional courtesy to call the pediatrician. So let's remember to do that. Parents are valued as members of the ED team who are accessible, honest, caring, and able to speak in lay language at a pace that match the parent's ability to process and comprehend, which may be much less than what we are able to process and comprehend. So take it slow. And parents recognize that you were the last person with that patient. So you are an important person now in their life. That little boy who died, the 9-year-old, I actually went to his funeral. That mom attached herself to me in ways I cannot describe. She called the ED the next day asking for me because she wanted to know if I knew of a funeral home that she could use. She called 2 days later because of something else. I was just a person that she had kind of attached herself to. But she also found me in that emergency department to send me notice of the funeral, and I actually went. I've been to 3. I went to one as a resident for a patient that I had taken care of for 4 years. He was an HIV patient. I went to one as a fellow of this poor child who I got to do every procedure under the sun in the PICU, when I really wanted to tell the parents to just run, take him and go. You don't have much time, but we still got to do, I got to do a lot on him. And I kind of went to the funeral as a kind of an apology from my end to say, I'm really sorry that I did all that to him. Consider a follow-up phone call to the family. It's actually documented that they actually really appreciate when we call to say, ask how they're doing, if there's anything else that they need. And then remember that this AAP ACEP technical report that came out said that care provided at the end of life is remembered by the bereaved for the rest of their life. So you do make a difference. So kind of coming back to family participation,